Welcome to PRISM Rounds, the audio journal club for busy ICU, ED, and pulmonary/critical care teams. Each episode breaks down one study at a time: clinical question, design, key results, limitations, and bedside relevance. So new evidence is easier to digest and apply in real-world practice. I started these episodes for my own learning and share them in case they are useful to other clinicians and learners. This podcast is for educational purposes only and is not medical advice. Clinical decisions should always be made in the context of the individual patient and treating team. Please like, subscribe, and share this episode with a colleague who may find it useful. In the March trial, routine carbocisteine or hypertonic saline did not shorten ventilation in ICU patients with difficult secretions, while carbocisteine increased clinically important GI bleeding and hypertonic saline increased bronchospasm and hypoxemia during nebulization.
So, picture this. It's day 5 in the intensive care unit.
Yeah. We all know day 5.
Right. You're standing right there at the bedside of an intubated patient, and the room just has that, that familiar rhythm.
The background noise of the ICU.
Exactly. You hear the mechanical sigh of the ventilator, the low hum of the monitors. And the good news is the patient's oxygenation is finally acceptable.
Which is a huge relief after a week of struggling.
Right. The whole team has been working nonstop. Sedation is finally weaning down. And you're starting to seriously think, maybe we can get this patient off the machine.
Thinking about extubation.
Yeah, extubation. But there is a massive catch.
There's always a catch.
There's always a catch. Every single time the nurse goes to suction the endotracheal tube, the catheter comes back with this just thick, tenacious, glue-like mucus.
Ugh, it's a visceral scenario. I mean, every single person who's worked a shift in an ICU knows that exact situation intimately.
It's just so frustrating to watch.
It really is. You have the respiratory therapist standing right there, looking really concerned. The bedside nurse is having to suction the patient, constantly.
And that's not just labor-intensive. It's really distressing for the patient.
Totally. You can literally hear the secretions rattling around in the corrugated plastic tubing of the vent circuit. And in that moment, the whole team just feels this intense, almost magnetic pressure to just do something.
Right. It's like an itch you feel compelled to scratch. You have to intervene. And inevitably, somebody on rounds is going to speak up.
Go.
Somebody points at the suction canister and goes, hey, should we start nebulizing hypertonic saline?
Yeah, the classic reflex.
And before you can even answer, somebody else chimes in, well, what about enteral carbocisteine? Let's thin that out.
Oh, yeah. Let's hit it from both sides.
Exactly. And almost like a reflex, one or both of those therapies just gets ordered. They get tacked on to the patient's already massive medication list.
Because treating it just feels right.
It does. When you see thick mucus, you want to fix it. It feels like you're actively solving a visible problem.
It feels like common sense. I mean, we are problem solvers in critical care. We see a blocked tube, we logically want to unblock it.
Of course we do.
But today, we are going to fundamentally challenge that clinical reflex.
Yes, we are.
Today's deep dive is really fueled by this incredible analysis put together by the PRISM Rounds team. They recently tackled a truly monumental piece of literature.
The March trial.
Yes, the March trial. That stands for Mucoactives in acute respiratory failure. Carbocisteine and hypertonic saline.
Catchy acronym.
Right. It was a massive randomized controlled trial published in the New England Journal of Medicine in 2026. This is PRISM Rounds, Season 1, Episode 50, by the way.
And our mission for this deep dive is to explore a concept that honestly trips up really smart people all the time.
It happens to the best of us.
It really does. We're looking at why physiologic plausibility does not always translate to actual patient outcomes.
That is the core issue here.
Yeah. So we're going to dissect the exact risk-benefit ratio of these mucoactive therapies in the ICU. And most importantly, we're going to build actionable, real-world de-implementation strategies that you can take straight back to the bedside.
De-implementation. That word is just the crux of this entire discussion today.
It's a tough word, both to say and to actually do.
Oh, absolutely. It's a really well-known phenomenon in evidence-based medicine that it is often much, much harder to stop doing something that's become deeply ingrained in medical culture than it is to start a brand new therapy.
Oh, totally. We get attached to our habits.
Right. So to de-implement, we have to unravel the psychology of why we do it in the first place, and then we have to look fearlessly at what the absolute highest level of evidence actually tells us.
So I want to set a zero hype baseline for us right out of the gate.
Good idea.
We are not looking at a trial today that shows some modest benefit,
Yeah.
or a trial where the data is kind of squishy and open to a million different subjective interpretations.
No squinting at p-values today.
Exactly. This isn't a situation where you try to justify saying, well, maybe in this one highly specific subgroup of patients it works. No.
Right.
This is a trial where the benefit side of the ledger is completely definitively empty.
Empty.
And the harm side, well, the harm side has very real, very measurable, and honestly quite alarming numbers attached to it.
Which is exactly why this trial is so important and why it is, quite frankly, practice-changing.
Absolutely practice-changing.
But to really understand the sheer impact of the Marchi trial, we can't just jump straight into the data. We first have to understand the underlying psychology.
And the physiology, right.
Yeah, the profound physiological theories that got us here in the first place. Like, why are ICU clinicians so stubbornly attached to these therapies?
Okay, let's unpack that. We have to start with what we can call the physiology trap.
The physiology trap, I like that.
Yeah, we need to look at why these critically ill patients make so much awful mucus in the first place, and why we think we can just easily fix it.
Right.
So, what is the actual pathophysiology of ICU mucus?
Well, to understand the pathology, let's first look at the brilliant engineering of a healthy airway.
Okay, baseline human anatomy.
Exactly. Normally, your upper airway, specifically your nasal cavity and the turbinates, it acts as this incredible, highly efficient, evolutionary HVAC system.
An HVAC system.
Yeah. It's a humidifier and a filter all rolled into one.
Right, because the air we breathe is usually pretty dry.
Exactly. When you take a breath of dry, cold room air, by the time that air reaches your lower trachea, it has been warmed perfectly to 37 degrees Celsius.
Body temperature.
Right. And it's 100% saturated with water vapor.
It's an amazingly rapid process when you think about it. The air is just conditioned instantly.
It is. And simultaneously, you have this microscopic defense system called a mucociliary escalator.
The escalator. I remember learning about that.
Yeah, the lining of your airway is covered in millions of these tiny hair-like structures called cilia. And these cilia beat in a perfectly synchronized wave, roughly 1,000 times a minute.
1,000 times a minute? That is wild.
It's incredibly fast. And they live in a watery layer called the periciliary liquid. And then sitting right on top of that watery layer is a sticky gel layer of mucus.
Okay, so a watery layer below, sticky gel on top.
Exactly. And the cilia are constantly sweeping this gel layer up and out of your lungs. They carry away inhaled dust, bacteria, cellular debris.
And you just either swallow it or cough it out.
Right, usually without even noticing you're doing it.
It's an invisible, perfectly tuned machine. But when a patient becomes critically ill and requires mechanical ventilation, we kind of completely hijack that beautiful evolutionary system, don't we?
We ruin it. We absolutely bypass it in the most brutal way possible.
Yeah.
We take a piece of plastic, an endotracheal tube, and we place it directly through the vocal cords and down into the trachea.
Right past all the filters.
Right past them. Suddenly, that entire highly evolved upper airway humidification system of the nose and pharynx, totally bypassed. We are blowing pressurized, totally dry gas directly into the lower airways.
Now, obviously, we try to artificially humidify that gas, right? Using heated wires and water chambers in the ventilator circuit.
We do, of course. But it is rarely as perfectly calibrated as actual human physiology.
No, the machines are good, but they aren't that good. And the endotracheal tube itself is a massive problem, too.
Oh, structurally, it's a nightmare.
It literally acts as a physical barrier preventing normal, effective coughing. You can't close your glottis to build up the intrathoracic pressure you need for a strong cough when there's a literal plastic tube stenting it open.
Exactly. So the mechanical clearance mechanism is just destroyed. And on top of that, consider the medications we're giving.
Oh, the sedation.
Right. The patient's almost always sedated, often very heavily. We give them propofol. We give them massive doses of opioids like fentanyl.
And those drugs totally suppress their central respiratory drive.
They do. They suppress the drive and their spontaneous reflex to cough and clear their own airway.
Okay, so let me summarize this. The plumbing is bypass, the mechanical pump is broken by the tube, and the software driving the pump is turned off by sedatives.
That is a very bleak but very accurate summary.
And then the mucus itself starts to change, doesn't it?
Yes, and this is where the rheology, the physical properties of the fluid, becomes an absolute nightmare.
Rheology. Okay.
Critical illness itself causes systemic inflammation. You have infection, you often have generalized dehydration or third spacing of fluids.
Patients are incredibly sick systemically.
Right, and this fundamentally alters the biology of the airway surface liquid. The inflammatory cascades cause the goblet cells in the airway to produce different types of mucin proteins.
Oh, so the actual recipe for the mucus changes.
Yes, these new mucins cross-link excessively. And remember that delicate, watery periciliary layer I mentioned?
The one the cilia live in.
Exactly. Well, that layer dries up, which means that thick, heavy gel layer crashes down directly onto the cilia.
Oh, wow. It literally crushes them.
It physically pins them flat so they can no longer beat.
So it sounds like the mucus stops acting like a fluid and starts acting more like, I don't know, rubber cement.
That is the perfect way to describe it. Rubber cement.
Hmm.
The volume of secretions might increase, but more importantly, the viscosity just skyrockets.
It's the perfect storm.
It really is. You have completely bypassed physiological humidification, totally impaired mechanical clearance because of the tube, suppressed neurological reflexes from the sedatives, and fundamentally altered highly viscous mucus rheology.
And the inevitable result is severe retention of secretions.
Right. These secretions block the smaller airways, leading to atelectasis where entire lobes of the lung just collapse.
Which is terrifying.
It leads to severe mucus plugging, profoundly impaired gas exchange, and ultimately a massive delay in weaning the patient off a mechanical ventilator.
It really is a mechanical and physiological nightmare. And, standing at the bedside, looking at that very real nightmare, it makes total logical sense that over the decades, the medical community aggressively looked for pharmacological solutions.
We wanted a pill to fix it.
We wanted magic drugs to fix the plumbing. So let's talk about the two drugs in question from the Marsiege trial, starting with carbocisteine. What is the theoretical whiteboard intervention here?
So carbocisteine is pharmacologically classified as a mucoregulator.
Okay, a mucoregulator.
In the ICU, it's typically given enterally, meaning we crush up a tablet or use a liquid suspension, and we push it down a nasogastric feeding tube directly into the stomach.
Okay, so it goes into the gut, not the lungs.
Right. The theoretical goal is that once it is absorbed systemically into the bloodstream, it works at the cellular level within the respiratory airway epithelium.
So it's not a direct contact drug, it works from the inside out.
Exactly. It's supposed to alter the actual intracellular synthesis of mucins, those massive glycoprotein complexes that make up the structure of mucus.
So it changes how the factory makes the product.
Yes, the biochemical idea is that it restores the normal physiological balance between silomucins and fucomycins.
Which means what exactly for the patient?
Essentially, the theory states that it changes the physical properties of the mucus at the exact moment it is being produced in the goblet cells. It's supposed to make it less viscous, far less sticky.
And theoretically, much easier for whatever functioning cilia are left to sweep away.
Or for the nurse to suction out.
Wow. It sounds incredibly elegant when you put it like that. You give a liquid down the feeding tube, and it fundamentally reprograms the hyperactive mucus factories in the lungs.
It treats the problem right at the source, theoretically.
Theoretically, right. So that's carbocisteine. Then we have the other option, hypertonic saline, which takes a totally different, much more physical approach.
Yes. Hypertonic saline is categorized as an expectorant strategy. Instead of going into the stomach, we nebulize it.
We turn it into a mist.
Right. We turn it into a very fine mist and administer it directly into the ventilator circuit so the patient inhales it straight into their lungs.
Okay. And the hypertonic part is key here, right?
Oh, absolutely. We are usually talking about a 6% or 7% sodium chloride solution, which has a much higher salt concentration than the surrounding bodily tissues.
Just for context, normal saline, like what's in an IV bag, is 0.9%. So this is massively concentrated salt water.
It is. It's incredibly salty. And because it's hypertonic, it relies on the basic biological principle of simple osmosis.
Ah, high school biology coming back to haunt us.
Exactly. The theoretical mechanism is that when you deposit this high salt concentration directly into the airway lumen, it creates a powerful osmotic gradient.
It pulls water.
It literally draws water out of the surrounding airway epithelial tissue and pulls it directly into the dehydrated mucus layer.
So it's designed to aggressively hydrate that thick, dried-out rubber cement mucus.
Yes, dramatically thinning it out, increasing the volume of the airway surface liquid, and theoretically making those dense secretions much looser and easier for the clinician to suction out.
Okay, here's where it gets really interesting and where I want to lean hard into this concept of the physiology trap.
Let's do it.
Both of these pharmacological mechanisms, reprogramming mucin synthesis with carbocisteine and using osmosis to rehydrate the airway with hypertonic saline. They sound absolutely flawless when you draw them on a whiteboard.
They make perfect sense.
But it's like assuming pouring a bottle of chemical drain cleaner down a kitchen sink will definitely 100% fix the plumbing without realizing the pipe is actually clamped completely shut by a metal bracket further down in the basement.
That is a phenomenal analogy. It perfectly highlights the gap between chemical action and systemic resolution.
Right. Plausibility is not proof. Just because carbocisteine might successfully thin out a sample of mucus in a sterile laboratory test tube.
Or just because nebulizing hypertonic saline might draw water into the airways of a walking, talking outpatient with a chronic disease like cystic fibrosis.
Exactly. That does absolutely not mean it is going to help an acutely ill, hemodynamically unstable, mechanically ventilated ICU patient with multi-organ failure actually get off the ventilator any faster. The context changes everything.
And that context gap is the exact chasm between beautiful pathophysiology and rigorous clinical evidence. In critical care, we have relied heavily on that whiteboard theory for decades.
We really have. It's just what you do.
In fact, if you look at international prescribing data, mucoactive agents are routinely used in over 80% of intensive care units worldwide.
80%.
Yeah, and they are given to roughly 20 to 30% of all patients receiving invasive mechanical ventilation. It's a massive, incredibly widespread intervention. We do it constantly.
But there was a review recently, right, that questioned all of this.
Yes, a major systematic review conducted in 2020 looked at this deeply ingrained practice and basically said, wait a minute, the actual randomized evidence for this in acute respiratory failure is incredibly weak.
Wow.
There was absolutely no high-quality data to either support or refute the use of carbocisteine in this population. And the data for hypertonic saline was wildly inconsistent, highly biased, and overall of very low quality.
Which brings us to why the Martz-Schurz trial is such a landmark piece of research. Because theoretical physiology wasn't answering the bedside question, and the existing literature was a mess, these investigators didn't just do, like, a small pilot study.
No, they went big.
They built a massive, pragmatic, ruthlessly designed machine to get definitive, real-world clinical answers.
They absolutely did. The sheer logistical scale of this trial is staggering. Let's look at the demographics and the setup because it really speaks to how much we can trust the results.
Okay, lay out the numbers for us.
This was a phase 3 multi-center open-label randomized controlled trial, and it took place across 71 different intensive care units across the United Kingdom.
71 ICUs. I really want to pause on that for a second because coordinating that is a logistical nightmare.
Oh, it's a massive undertaking.
That means this isn't just one highly specialized, weirdly specific academic quaternary center where they have a dedicated airway team and do things totally differently than the rest of the world.
Right.
This represents broad, messy, real-world practice across multiple different hospital trusts and cultures.
Exactly. It makes the results highly generalizable to the listener's own practice. They managed to enroll an impressive 1,956 critically ill patients.
Almost 2,000 patients? That's huge for an ICU trial.
It is. And the inclusion criteria were actually pretty straightforward.
Yeah.
These had to be patients 16 years of age or older who were currently on invasive mechanical ventilation for acute respiratory failure.
Okay, standard vent patients.
And crucially, they had to have difficult-to-clear secretions as determined by the subjective judgment of the treating clinical team.
Now let's talk about the statistical architecture of the trial, because this is where a lot of clinical raters might glaze over when reading the methods section.
Statistics can be dry, I know.
But it is actually the absolute genius of this study. It used a 2x2 factorial design. Can we demystify what that actually means for the listener? I feel like we hear factorial design thrown around all the time, but it rarely gets explained well.
I'd love to break it down because it's a wonderfully elegant statistical approach that saves millions of dollars and years of time.
Okay, I'm ready.
Normally, if you wanted to test carbocisteine, you'd run a massive trial of carbocisteine versus placebo.
Right.
And if you also wanted to test hypertonic saline, you'd have to find new funding, write a new protocol, and run an entirely separate massive trial of hypertonic saline versus placebo.
Which is incredibly inefficient.
Very. A 2x2 factorial design allows you to test both independent interventions at the exact same time within the exact same patient population.
Okay, let me try an analogy here to make sure I'm wrapping my head around this. Let's hear it. It's like trying to figure out what makes a cake taste better. Adding extra sugar or adding extra butter.
Okay, I'm following.
Instead of baking a baseline cake and then running a whole trial with a sugar cake and then a totally separate trial with a butter cake,
Yeah.
you just bake 4 cakes.
Ah, I see where you're going.
You have the baseline cake, the extra sugar cake, the extra butter cake, and 1 cake that gets both extra sugar and extra butter.
That is a perfect way to visualize it. Instead of 2 traditional buckets of patients, you create 4 buckets. The 1,956 enrolled patients were randomized into one of those 4 buckets.
Okay, walk us through the buckets.
Bucket 1, carbocisteine alone. Bucket 2, hypertonic saline alone. Bucket 3, both therapies given simultaneously. And bucket 4, usual care alone, meaning the patient received neither of the experimental mucoactive therapies.
And before we get to the actual results, let's lay out the specific dosages so clinicians listening know exactly what intervention was actually tested.
Good point. For the endocarbocisteine, the dose was 750 milligrams given 3 times a day.
TID.
Okay, TID. For the nebulized hypertonic saline, it was either a 6% or 7% concentration, depending purely on what the local hospital pharmacy stocked.
Which again highlights the pragmatic, real-world nature of the trial.
Exactly. And it was nebulized at a volume of 4 milliliters 4 times a day, QID.
Got it. And how long did they do this for?
The protocol stated both of these therapies could be continued for up to 28 days or until the patient was successfully liberated from the ventilator.
So going back to my cake analogy, how can they statistically test 2 different drugs at once without totally muddying the waters? Like, if a patient in bucket 3 gets better, how do you know if it was the carbocisteine or the saline that did it?
Ah, that is the million-dollar question.
This all hinges on a statistical concept called an interaction test, right?
Yes, precisely. The entire scientific validity of a factorial design rests on a statistical prerequisite. Before you look at the main outcomes, you have to formally check for a statistical interaction between the 2 drugs.
What does that mean in simple terms?
In simple terms, you have to ask the data. Does giving carbocisteine fundamentally change the way hypertonic saline works? Does giving one drug magnify or perhaps cancel out the effect of the other drug?
So back to the cake. If the extra sugar causes the extra butter to somehow curdle or bake weirdly, you have a problem.
Exactly. If they interact heavily, you can't easily separate their individual effects. You'd have to analyze them only as a combination therapy.
But they ran the interaction test in the Marsh-Each trial.
They ran the test, and the result was a p-value of 0.91 with a hazard ratio of 1.01.
Okay, let me translate that p-value 0.91 for everyone.
Please do.
That is a statistical way of screaming, these 2 drugs completely ignore each other.
Exactly.
They do not interact at all.
Biologically and statistically, they operate on completely independent tracks. And because they don't interact, it unlocked the true power of the trial design.
How so?
It meant the investigators didn't just have to look at the 4 small, fragmented buckets. They could combine them. They could look at everyone who received carbocisteine, whether they also happened to get saline or not, and compare them cleanly to everyone who did not receive carbocisteine.
Oh, wow. So they get to use the full sample size twice.
Yes. They could look at any carbocisteine versus no carbocisteine and any hypertonic saline versus no hypertonic saline. This effectively allowed them to use the full, massive statistical power of nearly 2,000 patients to answer 2 completely separate clinical questions simultaneously.
It is just brilliant trial design. It really maximizes the scientific value of every single patient who bravely enrolled in the study.
It really does.
So, with the trial architecture established as incredibly robust, massively well-powered, and rigorously executed across 71 different centers, we finally get to look at the ledger.
The moment of truth.
What did these therapies actually achieve? Did pouring the physiological drain cleaner actually clear the pipes? Did they actually get patients off the mechanical ventilator?
This is where we look at the primary outcome. And it's incredibly important to note how highly patient-centered this primary outcome is.
What do you mean by that?
Well, the investigators didn't measure how thin the mucus was in a suction trap. They didn't weigh the volume of secretions pulled out over 24 hours.
Right, because nobody actually cares about that in the grand scheme of things.
Exactly. The primary endpoint was time to first successful unassisted breathing, which had to be maintained for at least 48 hours without reintubation.
Which is exactly what actually matters. A terrified family member sitting out in the ICU waiting room doesn't care about the microscopic rheology or viscosity of their loved one's mucus.
No, don't.
They care about when their loved one is coming off the life support machine and breathing on their own. So, let's look at the results. I was looking at the data for carbocisteine first, and the numbers are fascinating.
Let's hear them.
The median duration of mechanical ventilation was 0.1 hours for the patients who received carbocisteine.
Okay.
For the patients who did not receive the drug, the median duration was 172.7 hours. The adjusted hazard ratio was 0.96 with a p-value of 0.34.
Okay, let's pause there.
Now, hold on. Let me push back a little here, or at least play devil's advocate for the bedside clinician looking at those raw numbers.
Go for it.
The median was 186.1 hours with the drug and 172.7 hours without it. That is roughly a 14-hour difference.
Yes, numerically.
The patients on the mucoregulator were numerically on the ventilator for longer. Should I interpret that as carbocisteine actively harming them by keeping my patients on the ventilator longer? Like, is it somehow prolonging their respiratory failure?
It is a totally natural human instinct to look at those two median numbers, see a 14-hour gap, and draw a straight causal line between them.
It's hard not to.
But this is where we have to apply data-focused rigor and understand the statistics. The key to answer your question is that p-value of 0.34.
The p-value is king.
Right. That p-value tells us that the 14-hour difference we see in the medians is entirely compatible with random chance. It is statistically neutral.
Meaning it's just noise.
Exactly. If we ran this exact trial 100 times with 100 different cohorts of ICU patients, we would expect to see variations of this size purely by statistical noise, just based on who happened to be enrolled that day.
Ah, I see.
Therefore, the mathematically and scientifically correct interpretation is simply a failure to show any benefit. It is not proof of prolongation, and it is not proof of harm regarding the duration of ventilation. It just didn't work.
Okay, understood. And just to clarify for the listener, a hazard ratio of 0.96. A hazard ratio basically measures the speed or the probability of an event happening in one group versus another over time, right?
Exactly. A hazard ratio of 1.0 means the event, in this case, getting off the ventilator, happened at the exact same rate in both groups.
And 0.96 is basically 1.0.
Yes, a ratio of 0.96 is so close to 1.0, and combined with that non-significant p-value, it completely confirms there is zero difference in the speed of liberation from the ventilator.
All right, so carbocisteine is a total wash. No benefit, but we shouldn't claim it inherently traps them on the vent. What about hypertonic saline? Did blasting the airways with hypersonal salt water do any better?
The data for hypertonic saline is even more starkly neutral.
Really? Let's hear it.
The median duration of mechanical ventilation was 184.5 hours with hypertonic saline, compared to 174.3 hours without it.
And the stats.
The adjusted hazard ratio was exactly 1.00. The p-value was 0.98.
A hazard ratio of exactly 1.00. I mean, you literally cannot get more null than that.
You really can't.
It is a perfect horizontal flat line of non-efficacy.
It truly is.
Yeah.
The therapies failed the primary test completely. But of course, in a major randomized trial of this size, you also have a massive dashboard of secondary outcomes.
Right. The investigators wanted to see if there was any hidden signal of benefit elsewhere.
Exactly. Sure, maybe it didn't speed up extubation, but did it help them survive? Did it get them out of the ICU faster overall? Did it prevent them from failing extubation and needing to be reintubated?
Right. Maybe it prevents mucus plugging post-extubation. So I'll run through that secondary dashboard because the results are pretty stunning.
Let's do it.
Day 28 mortality. It hovered right around 22% to 24% across all the groups with absolutely no significant differences.
No mortality benefit?
None. Neither drug saved lives. ICU length of stay. The median was identical across all groups. Exactly 14 days.
Identical.
Hospital length of stay. Unchanged. There was absolutely no improvement in the rate of successful extubation, and crucially, no reduction in the rate of reintubation.
So it didn't even help with the post-extubation plugging?
Nope. They even looked to see if it reduced the duration of antibiotic use or the need for intensive respiratory physiotherapy sessions. No difference whatsoever.
Across every single metric we care about in critical care, the ledger is completely empty.
So what does this all mean for how we practice? When we evaluate a drug, we usually talk about the number needed to treat, the NNT. Like, if I give this drug to X number of people, one person will experience a tangible benefit.
And this is a critical takeaway for the listener to internalize. There is no number needed to treat to calculate here.
Because there's no benefit.
Exactly. You literally cannot have an NNT when the clinical benefit is demonstrably non-existent. The NNT is effectively infinite.
An infinite NNT?
Yes. You could theoretically treat 1 million ventilated patients with these therapies, and based on this incredibly robust data, not a single one would get off the ventilator faster or survive their ICU stay. because of the drug.
An infinite NNT. That is a deeply sobering thought when you consider how casually and how frequently these medications are ordered on rounds.
It really is.
Which brings us to the absolute most critical part of this entire deep dive. In critical care, we are constantly, meticulously balancing scales. We weigh the potential benefit against the potential harm of every single intervention.
That's the core of medicine.
But if a therapy has an infinite NNT, meaning zero measurable benefit, then any measurable harm, no matter how small or statistically rare, tips the scales violently into the danger zone.
We are no longer balancing risk and reward. We are just administering risk.
Exactly. So what did these drugs actually cost the patients?
This is where we have to translate the trial's safety outcomes into actionable bedside metrics. We need to look closely at the number needed to harm, the NNH. Let's start with carbocisteine.
Right. I was looking at the safety dashboard for carbocisteine, and the gastrointestinal bleeding numbers actually made me stop reading and double-check the chart.
Yes, it's surprising. The investigators looked specifically at clinically important upper gastrointestinal bleeding. In the group receiving any carbocisteine, this occurred in 1.4% of patients.
Okay, 1.4%. And the control group?
In the control group, it occurred in only 0.2%. The risk ratio was 6.51 and the p-value was 0.01.
A risk ratio of 6.51. That means the patients who had carbocisteine pushed down their feeding tubes were over 6 times more likely to have a clinically important GI bleed. Let's break that down into an absolute risk increase and the number needed to harm.
The absolute risk increase is roughly 1.1%. When you convert that percentage to a number needed to harm, you get approximately 88.
Okay, so NNH of 88. Let me translate that. For every 88 ventilated ICU patients that we decide to blindly give carbocisteine to, we are actively causing one clinically important upper GI bleed. And let's think about what that means clinically. We are causing an event that requires intervention, maybe dropping their hemoglobin enough to require blood transfusions, maybe requiring an emergent endoscopy in a patient who is already critically ill, likely on high PEEP, and hemodynamically fragile.
And we're doing it for a drug that provides zero respiratory benefit.
It's maddening.
It is. And I think it's important to explain why this happens. Remember what carbocisteine is designed to do. It alters mucin synthesis to make mucus thinner.
Right, it stops the thick mucus production.
While the stomach lining relies heavily on a thick, robust layer of gastric mucus to protect itself from the highly acidic environment of the stomach.
Oh, of course.
Right. If you give a drug systemically that impairs mucus formation, you are systematically degrading the stomach's natural defense mechanism.
You're stripping the stomach's armor.
Exactly. In an ICU population where patients already have a high incidence of stress ulcers and coagulopathies, degrading that gastric mucosal barrier is a recipe for disaster.
That makes total sense.
While 1.4% sounds like a low absolute number, an iatrogenic GI bleed is a massive, potentially life-threatening complication. It is entirely unacceptable when the drug offers zero upside.
That makes perfect physiological sense. The drug doesn't just target the lungs, it targets mucus everywhere, including the stomach lining that desperately needs it.
Exactly.
Now let's look at hypertonic saline. This one has always made me a bit nervous at the bedside anyway, because you're taking a highly concentrated hyperosmolar solution and aggressively inhaling it into an already inflamed reactive airway. What did the MARSH trial find regarding harms for the saline?
They found two very clear, very concerning, and frankly predictable safety signals with hypertonic saline. The first was severe bronchoconstriction.
How severe are we talking?
Specifically, bronchoconstriction that was severe enough to require the administration of a rescue bronchodilator. This adverse event occurred in 2.4% of the hypertonic saline group, compared to just 0.4% in the control group.
Wow.
The risk ratio was 5.73, with a highly significant p-value of 0.001.
So almost a 6-fold relative increase in bronchospasm. What is the NNH there?
The NNH is approximately 51.
Okay, an NNH of 51.
For every 51 patients you treat with nebulized hypertonic saline, you cause an episode of bronchoconstriction severe enough to require rescue therapy.
And again, let's look at the mechanism. When you inhale a 7% saline mist, it is intensely irritating to the smooth muscle lining the airways.
It burns.
Yeah. The body registers this hyperosmolar solution as a chemical attack. The epithelial cells actually lose water to the hypertonic fluid. They shrink, they release inflammatory mediators, and the smooth muscles spasm in defense. That's your bronchoconstriction.
That's exactly what's happening physiologically.
But there was a second, even more frequent harm.
Yes, and this one is arguably more dangerous in the moment. Hypoxemia during nebulization.
Desaturation.
Yes. This happened in 4.1% of patients actively receiving the hypertonic saline nebulizer versus only 0.3% of the control group.
Those numbers are wild.
The risk ratio is a massive 13.29 with a p-value of less than 0.001.
A 13-fold increase in acute hypoxemia. And the absolute numbers give us what? NNH.
An NNH of approximately 26.
Okay, let's put that NNH of 26 into a visceral perspective.
Let's do it.
If you work in a 26-bed ICU and the entrenched culture of your unit is to just reflexively put everyone with thick secretions on hypertonic saline, you are mathematically guaranteeing one episode of iatrogenic treatment-induced hypoxemia during your rounds.
It's guaranteed.
I've seen this happen. You have a patient who is already on 60% FiO2 and 10 of PEEP, struggling to maintain a saturation of 90%.
On a knife's edge.
Exactly. You hook up the hypertonic saline neb, and 5 minutes later, the alarms are blaring. They're desaturating to the 70s. The nurse is rushing in. You're considering paralyzing them or increasing the PEEP. All because you irritated their airways with salt water.
All for an intervention that doesn't actually get them off the vent faster.
Right. You are causing a massive desaturation event in a patient who is literally on a ventilator because they are already struggling to oxygenate. A 4% event rate sounds small if you are looking at it in a vacuum or maybe in an outpatient clinic. But it is massive, it is glaring, and it is dangerous when the benefit side of the equation is zero.
It is the absolute definition of low-value, high-risk care in this specific context. You are proactively introducing acute instability to an already fragile physiological system for absolutely no reward.
It's just hard to justify. Now, before we tell everyone listening to go back to their units, rip up their order sets, and totally abandon these therapies in the ICU, we have a scientific obligation to rigorously stress test the trial itself.
We have to be thorough.
Right. Because if we're going to change decades of established practice, we have to be absolutely sure. Could a flaw in the March-H trial methodology be hiding a true benefit? Let's appraise the trial, starting with the strengths.
The methodological strengths are really formidable here. We already mentioned the massive size of nearly 2,000 patients and the highly pragmatic inclusion of 71 diverse ICUs.
Right. Massive scale.
That gives incredible statistical power and immense real-world applicability. But beyond that, they achieved very high protocol adherence, around 85%.
85% adherence.
Yes, which is exceptionally good for a complex ICU trial of this scale that spans up to 28 days of treatment.
That is really impressive.
And crucially, they had minimal loss to follow-up. Less than 3% of the primary outcome data was missing. That means we can deeply trust the integrity of the final data set.
But no trial is perfect, right? And this is where the skeptics will attack the findings. The biggest target on this trial's back is that it was an open-label trial.
The open-label design, yes.
Meaning the doctors, the respiratory therapists, and the nurses all knew exactly what the patient was getting. There was no placebo saline or placebo feeding tube liquid. And because of that open-label design, there was contamination. Some patients in the control group who were strictly randomized to not get mucoactives ended up getting them anyway because the clinical team felt they really needed them and essentially broke protocol.
It happens in pragmatic trials.
So I have to push back here. Doesn't that contamination bias the results heavily toward the null? If a chunk of the control group is secretly getting the active drug, doesn't that artificially hide a benefit, making the two groups look identical when they really aren't?
That is a very sophisticated epidemiological question and is the exact right question to ask of any open-label trial. Yes, contamination almost always risks diluting the treatment effect.
Right, the lines get blurred.
If enough control patients get the active drug, the control group starts acting exactly like the treatment group, and any difference vanishes. However, the March investigators were brilliant. They anticipated this exact criticism.
Well, they did.
Yes. They didn't just rely on the standard intention-to-treat analysis. They proactively performed a highly advanced statistical model called a complier average causal effect analysis, or CASE.
A CASE analysis. Okay, we definitely need an analogy for this one because that sounds intense. Explain CASE to us.
Okay, let's imagine you're running a trial to figure out if a strict new diet works for weight loss.
Okay, diet trial.
But it's open label, and half the people in the no diet control group are secretly sneaking the diet food because they want to lose weight too.
Cheating on the study.
Right. If you just compare the two groups at the end, the diet looks like a failure because everyone lost weight. A KC analysis is like a mathematical lie detector.
A mathematical lie detector?
I like that.
It uses complex modeling to isolate the true signal of the intervention only among the people who actually followed the rules. It mathematically adjusts for the non-compliers and the contaminated control patients.
So it filters out the noise from the cheaters.
Exactly. It estimates what the true effect of the drug would have been if absolutely everyone had perfectly adhered to the protocol.
That is a fantastic way to explain it. So what happened when they ran this lie detector test on the MARCS data?
When they ran the CCE analysis, the results were identical.
Identical.
The findings remained completely null. The lack of benefit isn't a statistical illusion caused by contamination or protocol breaches. The lack of benefit is real.
That is a tremendously powerful statistical defense.
Yeah.
It means the null result is rock solid. What about the inclusion criteria? Let's talk about the subjective secretion problem, because I think this is where the biology gets muddy.
This is a really vital clinical nuance. The trial enrolled patients based entirely on a clinician's subjective judgment that the patient had difficult-to-clear secretions.
Right, there wasn't a lab test for it.
No, there was no standardized objective biomarker. There was no quantified secretion volume score, no rheological measurement of the mucus viscosity in a lab. It was basically a doctor, nurse, or RT looking at a suction tube and saying, wow, that looks thick.
Right. And as we know from working with different teams, what I think is thick mucus might be very different from what a senior 20-year veteran respiratory therapist thinks is thick mucus. It introduces massive heterogeneity into the patient population.
Exactly. It means the trial population, while wonderfully reflective of messy real-world practice, probably included patients with a massive variety of underlying pathologies causing their secretions.
Oh, for sure.
Some might have had true inflammatory use and hypersecretion. Others might have just been systemically dehydrated.
Or they just had a dry vent circuit.
Right. Others might have had inadequate ventilator humidification because a heater wire was broken. Some might have just had a weak cough due to oversedation or even transedative fluid from left ventricular failure.
And a single pharmacological drug is absolutely not going to fix all those completely different underlying mechanisms.
Not a chance.
So this leaves the door open, just a tiny crack, for the idea that maybe there is a highly specific subphenotype of ICU patients with true mucin hypersecretion who might benefit, but we simply lack the bedside diagnostic tools to identify them right now.
That's a fair scientific caveat. It's totally possible. But until we have those diagnostic tools, empiric widespread prescribing is clearly causing more harm than good.
And speaking of different pathologies, we absolutely need to issue a massive, flashing neon extrapolation warning here for our listeners.
Oh yes, please do.
We are talking strictly about acute respiratory failure in the intensive care unit.
Yes, this is crucial. Do not misinterpret this trial. The March-Age trial applies only to the acute, mechanically ventilated ICU patient.
So it doesn't apply to chronic patients.
It does absolutely not mean you should stop prescribing mucoactive therapies in a patient with cystic fibrosis or someone with severe non-cystic fibrosis bronchiectasis.
Because the biology is totally different.
The underlying biology of chronic suppurative airway disease is entirely different from acute mechanical ventilation. Those chronic patients have totally different mucin profiles, fundamentally different inflammatory cascades, and a massive, well-established evidence base supporting their specific therapies.
So you can't just cross-apply the data.
You cannot take an ICU trial and apply it to a cystic fibrosis outpatient clinic.
That context is everything. Okay, so we've established that the trial is methodologically robust, the drugs definitively do not work for this acute ICU indication, and they cause active, measurable harm to our patients.
The data is clear.
If the data says stop, why is it so incredibly hard to actually stop? We have to address the psychology of ICU culture and figure out what we should do instead. Let's talk about de-implementation.
De-implementation is often the hardest part of evidence-based medicine. We are fighting decades of ingrained, comfortable habits.
I think it comes down to the psychology of visible problems, which we touched on at the beginning.
Right. The need to act.
In the ICU, so much of what we treat is entirely invisible to the naked eye. We treat numbers on a screen, blood pressure, oxygen saturations, sodium levels, lactate.
We treat data.
But thick secretions are one of the very few tangible, physical, gross problems we can see with our own two eyes. You can literally watch the thick yellow mucus globbing up in the suction tubing.
It's right there in front of you.
It provokes a deeply visceral reaction. Giving a medication, writing that order for hypertonic saline in the computer, it fundamentally treats the clinician's anxiety of seeing the mucus, even if the data proves it doesn't help the patient. It perfectly satisfies our bias for action.
It is the ultimate commission bias. As humans, and especially as doctors and nurses, we feel vastly better doing something rather than doing nothing, even when doing nothing is the safer option.
It's hard to just stand there.
But when doing something actively causes GI bleeds and life-threatening hypoxemia, we have a moral obligation to retrain our clinical instincts. We need to build a framework for listeners to take back to their units and use on rounds tomorrow.
So let's build that framework. What are the actionable de-implementation strategies?
Step 1 is systemic. You need to look at your hospital's standardized ventilator order sets and your respiratory therapy protocols.
The actual computer system?
Yes. If carbocisteine or hypertonic saline are checked off by default, or if they are easily available as a reflexive PRN order for thick secretions, they need to be aggressively removed from those bundles.
You have to make it harder to order.
You have to create administrative friction. If a clinician really truly believes they need to use them for a specific edge case, they should have to actively search for the order, type it in manually, and justify it, rather than just mindlessly clicking a pre-check box.
Make the wrong thing harder to do. I'd love that. Systemic friction is the best way to change culture. What is step 2?
Step 2 is cultural and conversational. You have to actively challenge the reflex on multidisciplinary rounds.
How so? Like, what do you actually say?
When the bedside nurse or the respiratory therapist says, "Secretions are thick this morning, should we start HTS?" the attending physician or the senior resident needs to pause and ask a clarifying question.
What's the question?
What specific patient-centered outcome are we hoping to change here, knowing that the March trial showed it won't shorten their ventilator time and might cause bronchospasm?
Wow, that's a great question.
It immediately changes the conversation from "let's fix the mucus" to "let's fix the patient."
But we can't just leave the bedside nurse or the respiratory therapist hanging. We can't just say, "No drugs for you. The data says it's bad. Good luck dealing with the glue in the tube."
No, we definitely can't do that.
If we aren't using these pharmacological agents, what do? We have to replace the bad habit with a good evidence-based habit.
Exactly. We refocused the entire team on high-value foundational airway care. And the absolute basics are actually incredibly powerful when done meticulously.
Okay, let's list them out. What's number 1?
Number 1, ensure absolute perfection in ventilator humidification. This is paramount.
It seems so obvious, but it's often overlooked.
It really is. Are the heater wires in the circuit actually working? Is the water chamber full? Is the temperature set correctly to body temperature? Very often, thick secretions are simply a mechanical sign of an underhumidified, dry ventilator circuit.
Right, it's basic plumbing. If the pipe is dry, add water to the mechanical system. Don't add hyperosmolar salt to the patient's delicate airway.
Precisely. Number 2, optimize the patient's systemic hydration status, provide they aren't grossly fluid overloaded or in florid heart failure. Systemically dehydrated patients make dehydrated viscous mucus.
Right. Hydrate the patient, hydrate the mucus. What's number 3?
Number 3, minimize sedation aggressively. We want the patient awake, interacting, triggering the ventilator, and utilizing whatever spontaneous natural cough reflex they have left.
Because the drugs turn off the cough.
Right. A patient who is heavily sedated with propofol cannot clear their own airway, no matter how much drug you give them.
And we have to get them physically moving. Gravity is our friend.
Yes. Number 4, work closely with your physical and respiratory therapists on positioning, frequent turning, and early mobility.
Just getting them upright helps.
Sitting a patient up in a chair, getting them out of bed, utilizing gravity and changing chest wall mechanics. These are incredibly potent, proven airway clearance techniques.
And finally,
Consider targeted interventions like bronchoscopy, but only for highly suspected lobar collapse or major life-threatening mucus plugging.
right, it's not a routine cleaning service.
Exactly. Bronchoscopy is a highly invasive procedure. It is not for routine airway clearance. It is a targeted rescue procedure for a specific anatomical blockage.
So we replace the reflexive harmful drug order with meticulous, team-based attention to the physical mechanics of the airway, the ventilator, and the patient's mobility.
Exactly. It requires significantly more thought, more coordination, and more physical effort from the entire ICU team than just simply prescribing a nebulizer. But it is actually high-value, evidence-based critical care.
We have covered a massive amount of ground today. We've gone from the microscopic beating of respiratory cilia to the complex statistical architecture of a 2,000-patient trial, and ended with practical bedside maneuvers.
It's a lot to process.
Let's bring it all home for the listener. Let's do the rapid-fire synthesis. Give me the 5 concise take-homes that our listeners can pocket and take to their next shift.
Okay, here's the final synthesis. Point number 1. The MARCH trial was a massive, highly robust 2x2 factorial randomized controlled trial conducted across 71 UK ICUs investigating mechanically ventilated patients with difficult-to-clear secretions.
Check. Massive UK trial.
Point number 2. The primary outcome was definitive. Neither enteral carbocisteine nor nebulized hypertonic saline shortened the duration of mechanical ventilation compared to usual care.
Point 2. It doesn't get them off the vent faster.
Right. Point number 3. There is no number needed to treat to calculate. There was 0 demonstrated clinical benefit in weaning time, intensive care length of stay, or overall mortality. The efficacy is entirely null.
Point 3. Infinite NNT. 0 benefit.
Point number 4. Both therapies caused measurable significant harm. Carbocisteine increased the risk of clinically important upper GI bleeding, with a number needed to harm of roughly 88.
NNH 88 for GI bleeds.
And hypertonic saline increased the risk of severe bronchoconstriction, requiring rescue therapy, with an NNH of 51, and induced hypoxemia during nebulization, with an incredibly high NNH of approximately 26.
Point 4. Real tangible harms. NNH 51 for bronchospasm, NNH 26 for desaturation, and the final point.
Point number 5. The actionable bedside mandate is clear. Stop reflexive prescribing, de-implement routine mucoactives from your ventilator bundles and order sets, and instead focus the multidisciplinary team's energy on airway clearance basics, optimal mechanical humidification, early mobility, and careful clinical phenotyping.
That is an absolutely brilliant summary of complex data. And to wrap up this deep dive, I want to leave you, the listener, with a final, slightly provocative thought to chew on during your commute or your next night shift.
I love a provocative thought.
We talked a lot today about the psychology of the ICU and commission bias. The next time you are standing at that bedside, listening to the alarms ping, watching that thick, tenacious yellow mucus crawling up the suction tube, and you feel that overwhelming magnetic urge to just order a mucoactive drug to make it go away. Take a breath and ask yourself a very hard question.
This question.
Are you actually treating a patient-centered problem, hoping to genuinely get them extubated faster? Or are you, in that specific moment, just treating your own anxiety and discomfort with seeing a messy airway?
Wow. It is a profound question that requires a lot of honesty and self-reflection to answer, but it is the exact question that separates truly evidence-based medicine from reflexive, habit-driven care.
Thank you for joining us for this deep dive into the Merck to CH trial. We hope this arms you with the data, the statistical understanding, and the perspective you need to provide the best possible care for your patients. Take this information back to your units, share it with your respiratory therapist, discuss it openly on rounds, and continue the conversation. Until next time, keep questioning what you do and why you do it.
Thanks for spending your time with PRISM Rounds. If this episode was useful, please like, follow, or subscribe, and share it with a colleague. Leave a comment with your bedside takeaway, a question, or a paper you'd like covered next. Your feedback helps shape future episodes. Thanks again for listening. Educational use only, not medical advice.
On a dark desert ICU corridor, cool wind in my hair, warm smell of the humidifiers rising through the air. Welcome to the results of the MARCH trial, such a hopeful place, but no change in face. Plenty of data, the results of the MARCH trial, any time of year. The endpoints are clear.